Hello, dear students. My name is Herasimionak, and today I will speak out about interventional techniques in cardiology, indications for cardiac surgery. Cardiac catheterization and coronary angiography. This is the first title. Diagnostic cardiac catheterization and coronary angiography are considered the gold standard in the assessment of the anatomy and physiology of the heart and its associated vasculature. Cardiac catheterization and coronary angiography are indicated to evaluate the extent and severity of cardiac disease in symptomatic patients and to determine if medical, surgical, or catheter-based interventions are warranted. They are also used to exclude severe disease in symptomatic patients without equivocal findings on non-invasive studies and in patients with chest pain syndromes of unclear etiology or whom a definitive diagnosis is necessary for management. What are the indications for cardiac catheterization and coronary angiography? Asymptomatic or symptomatic patients. First of all, we have to estimate does patient has high risk for adverse outcomes based on non-invasive tests. Sudden cardiac death risk, presence of sustained more than 30 seconds monomorphic ventricular tachycardia or non-sustained less than 30 seconds polymorphic ventricular tachycardia in anamnesis. Symptomatic patients. First of all, this is patients which has Canadian Cardiology Society class 2, 3 or 4 stable angina on medical therapy, acute coronary syndrome, chest pain syndrome or unclear etiology and equivocal findings on non-invasive tests. ST segment elevation acute myocardial infarction, reperfusion with primary percutaneous coronary intervention, persistent or recurrent ischemia, pulmonary edema and recurrent reduced ejection fraction, cardiogenic shock or hemodynamic instability, risk stratification or positive stress test after acute myocardial infarction, mechanical complications, mitral regurgitation, ventricular septal defect, valvular heart disease, suspected severe valve disease in symptomatic patients, dyspnea, angina, heart failure, syncopes, infarctive endocarditis with need for cardiac surgery, asymptomatic patients with aortic regurgitation and cardiac enlargement or reduced ejection fraction, prior to cardiac surgery in patients with suspected coronary artery disease, congestive heart failure patients, new onset with angina or suspected undiagnosed coronary artery disease, new onset cardiomyopathy or an uncertain cause of or suspected to be due to coronary artery disease, congenital heart disease, prior to surgical correction when symptoms or non-invasive testing suggest coronary disease, suspicion for congenital coronary anomalies. And then let's discuss about techniques. First of all, this is vascular access. Cardiac catheterization procedures are performed using a percutaneous technique to enter the femoral radial artery and femoral brachial or internal jugular vein as the access site for the left and right heart catheterization, respectively. A flexible sheath is inserted into the vessel over a guide wire, allowing diagnostic catheters to be introduced into the vessel and advanced toward the heart using fluoroscopic guidance. The radial artery, or rarely the brachial artery, access site is advantageous in patients with peripheral arterial disease that involves the abdominal aorta, iliac, or femoral vessels. Severe iliac artery tuberosity, morbid obesity, or preference for early post-procedure ambulation. Use of radial artery access is also gaining popularity due to a lower rate of access site bleeding complications. This is transradial approach, background transradial access, which has a minimal risk of problems such as radial artery occlusion, hemorrhage, spasm, and so on, is now considered the standard procedure for cardiac catheterization. This is new one method, distal radial approach. The distal radial access is an easily applicable and safe method for cardiac angiography and PCI compared to the right conventional radial access, and the patients are more satisfied after such an approach. Next is right heart catheterization. This procedure measures pressures in the right heart and pulmonary artery. Right heart catheterization is no longer a routine part of diagnostic cardiac catheterization, but it is reasonable in patients with unexplained dyspnea, pulmonary hypertension, valvular heart disease, pericardial disease, right or left ventricle dysfunction, congenital heart disease, and suspected intracardiac shunts. Right heart catheterization most commonly uses a balloon-tipped flotation catheter that is advanced sequentially to the right atrium, right ventricle, pulmonary artery, and pulmonary wedge position, using fluoroscopic guidance. In each cardiac chamber, pressure is measured and blood samples are obtained for oxygen saturation analysis to screen for intracardiac shunts and calculate a cardiac output. Please look at this figure. This is placement of the pulmonary artery catheter guided by characteristic of normal vascular pressure and waveforms. For placement in the left internal jugular vein or left subclavian vein, one should add 5 centimeters to each of landmarks. CVP, central venous pressure, PAC, pulmonary artery pressure, and PAP, this is pulmonary artery pressure, and RVP, this is right ventricular pressure. All of these diagrams and curves you can observe in this figure. This is different parts of heart chamber and pulmonary artery, where we can estimate blood pressure, chambers pressure, and saturation. Next is left heart catheterization. This procedure measures pressures in the left heart as a determinant of the left ventricular performance. With the aid of fluoroscopy, a catheter is guided to the ascending aorta and across the aortic valve into the left ventricle to provide a direct measure of left ventricular pressure. In patients with a tilting disc prosthetic aortic valve, crossing the valve with a catheter is contraindicated, and the left heart may be assessed via transeptal technique from the right atrium using a needle-tipped catheter to puncture the atrial septum at the fossa ovalis. Once the catheter crosses from the right to the left atrium, it can be advanced across the mitral valve to the left ventricle. This technique is also used for mitral valvuloplasty. And next is coronary angiography. Selective coronary angiography is almost always performed during cardiac catheterization and is used to define the coronary anatomy and determine the extent of epicardial coronary artery and coronary artery bypass graft disease. The normal coronary anatomy is highly variable between individuals, but in general there are two coronary ostia and three major coronary vessels: the left anterior descending, the left circumflex, and the right coronary arteries, with the left anterior descending and left circumflex arteries arising from the left main coronary artery. Here is the picture of coronary arteries, and here you can see the main coronary arteries. The first one is right coronary artery, which arising from the aorta. Right coronary artery supplying blood to right atrium, to right ventricle, to SA node, to AV node. Next is left coronary artery, which bifurcates onto two main branches. First is left anterior descending artery, which predominantly supply blood to left ventricle and left atrium, and left circumflex artery, which supply blood to lateral part of left ventricle and to posterior part of left ventricle. Coronary angiography visualize coronary artery stenosis as luminal narrowing and the Cine angiogram. The degree of narrowing is referred to as the percent stenosis and is determined visually by comparing the most severely diseased segment with a proximal or distal normal segment. A stenosis above 50% is considered significant. Here is the video with cardiac and coronary angiography. This is cardiac catheterization. During an angiogram, catheter is inserted into an artery and up to the heart. So you can see here how catheter is inserted into the femoral artery and advanced up the aorta to the heart. This is the most common approach for cardiac catheterization. So this is angiographic imaging. During an angiogram, catheter is inserted into the artery and up to the heart, and you can see here this is the place where catheter tip is positioned, and from this place we are starting to inject contrast dye. And once in place contrast dye is injected into the bloodstream, the X-ray machine takes a series of images which will show any areas of narrowing. This procedure is done as a part of cardiac catheterization procedure. So here you can see all main coronary vessels. and right coronary artery injected with X-ray, contrast dye to show blockage or nerving of the inside of the artery, and here is narrowing of right coronary artery, you can see here. So what we can conclude, this is thin place of the right coronary artery. This is the place of atherosclerotic lesion. This is coronary angiography. So this is three figures. Figure A, coronary angiogram showing the left circumflex artery in its obtuse marginal branch. The left anterior descending artery is also seen, but maybe foreshortened in this view. Figure B, the LAD and its diagonal branches are best seen in cranial views. In this angiogram, the left main coronary artery is also seen. And figure C, the right coronary artery gives off the posterior descending artery. So this is a right dominant circulation. This is real-time coronary angiography. This is cineangiographic imaging, shows a right anterior oblique view of the left coronary system with total occlusion of left circumflex. Here is occlusion of left circumflex coronary artery. Here is, yes, total occlusion. So stop contrast is here. Look again. This is stop contrast here. And narrow, you can pay attention at narrow right coronary to this ventriculography and aortography. Ventriculography to assess left ventricle function may be performed during cardiac catheterization. A pigtail catheter is advanced retrograde across the aortic valve into the left ventricle, and 30 to 45 milliliters of contrast is powered injected to visualize the left ventricular chamber during the cardiac cycle. The ventriculogram is usually performed in the right anterior oblique projection to examine wall motion and mitral valve function. Normal wall motion is observed as symmetric contraction of all segments. Hypokinetic segments have decreased contraction, akinetic segments do not contract, and dyskinetic segments appear to bulge paradoxically during systole. Ventriculography may also reveal a left ventricular aneurysm, pseudoaneurysm, and diverticulum, and can be used to assess mitral valve prolapse and the severity of mitral regurgitation. The degree of mitral regurgitation is estimated by comparing the density of contrast opacification of the left atrium with that of the left ventricle. Ventriculography performed in the left anterior oblique projection can be used to identify a ventricular septal defect. A calculation of the ventricular volumes in systole and diastole allows calculation of stroke volume and cardiac output. This is ventricular gram and diastole and systole phase. So, in patients with normal left ventricular function, the ventriculogram reveals symmetric contraction of all walls. You can see here, this is end-diastole phase and this is end-systole phase. All walls are contracted well. Patients with coronary artery disease may have wall motion abnormalities on ventriculography as seen in this 60 years old male following a large anterior myocardial infarction. In systole, the anterior apical and inferior walls are akinetic. Yes, look at and compare to this picture. Yes, and akinetic. So if we compare with diastolic phase, no changes revealed during systolic phase. So this part of heart is akinetic. It doesn't contract at all. Left ventricular angiogram shows inferolateral hypokinesis in left anterior oblique view. Look at this part of the left ventricle, and you can notice that this part is akinetic. Yes, so this is systole, and we know this wall motion, but here no motions at all. This is akinetic, this is infarction region. Ventriculography and aortography. So aortography in cardiac catheterization laboratory visualize abnormalities of the ascending aorta, including aneurysmal dilation and involvement of the great vessels, as well as dissection with compression of the true lumen by an intimal flap that separates the true and false lumina. Aortography can also be used to identify patient saphenous vein grafts that elude selective cannulation, identify shunts that involve the aorta, such as patient ducts arteriosus, and provide a qualitative assessment of aortic regurgitation using a 1-to-4 scale similar to that used for mitral regurgitation. Patent. Sorry. Normal thoracic aortogram in right posterior oblique projection. Yes, you can see here, this is aortogram, and this is contrasted aorta. Intravascular ultrasound, optical coherence tomography, and fractional flow reserve. This is next three methods of visualization which we're using in cardiology. During coronary angiography, intermediate stenosis, indeterminate findings or anatomic findings that are incongruous with the patient's symptoms may require further interrogation. In these cases, intravascular ultrasound provides a more accurate anatomic assessment of the coronary artery and the degree of coronary atherosclerosis. IVUS is performed using a small flexible catheter with a 40 MHz transducer at its tip that is advanced into the coronary artery over a guide wire. Data from IVUS studies may be used to image atherosclerotic plaque precisely, determine luminal cross-sectional area, and measure vessel size. It is also used during or following percutaneous coronary intervention to assess the stenosis and determine the adequacy of stent placement. This is intravascular ultrasound. Coronary stenosis and cineangiogram and intravascular ultrasound. Significant stenosis in the coronary artery are seen as narrowing black arrows of the vessels. The intravascular ultrasound shows a normal segment or artery. This is figure A. This is part of coronary artery. Areas with eccentric plaque, B and C. You can see this light region. This is atherosclerotic plaque. B and C. On this picture you see no signs of stenosis, but plaque is markable. And here C also not markable changes by angiogram, but a really serious stenosis by ultrasound. And D, this is obliteration of the lumen at the site of the significant stenosis. Here is only light region you see here, and this is significant stenosis, and this is near this black arrow, so this is the place of obliteration. Optical coherence tomography is a catheter-based imaging technique that uses near infrared light to generate images with better spatial resolution than IVUS. However, the depth of field is smaller. The advantage of OCT imaging over IVUS lies in its ability to image characteristics of atherosclerotic plaque, lipid, fibrous cap, with high definition, and to assess coronary stent placement, apposition, and patency. This is optical coherence tomography pictures, imaging. Optical coherence tomography imaging, the optical coherence tomography catheter in the lumen of coronary artery with limited new intima formation. This is figure A. The intima is seen with high definition, but unlike intravascular ultrasound imaging, the vessel media and adventitia are not well visualized. B. Fibrous plaque arrow. Yes, this is fibrous plaque. Is characterized by a bright signal. C. A large eccentric lipid-rich plaque obscures part of the vessel lumen. Yes, this is very big atherosclerotic plaque. Because lipid in the plaque absorbs light, lipid-rich plaque appear as a dark area with irregular borders. Yes, a lot of lipids, a lot of black areas here. So the plaque is covered by a thin fibrous cap. Yes, this is thin fibrous cap, light region, typical of vulnerable plaque. So this is vulnerable plaque. It may be cover may rupture with thrombosis. A thrombus. Next figure, adherent to a ruptured plaque that is protruding into the vessel lumen. E. A coronary stent. This is coronary stent. That is well opposite to the vessel wall. The stent struts appear as short bright lines with dropout behind the struts. Fractional flow reserve. Measurement of the fractional flow reserve provides a functional assessment of the stenosis and is more accurate in predicting long-term clinical outcomes than imaging techniques. The fractional flow reserve is the ratio of pressure in the coronary artery distal to the stenosis divided by the pressure in the artery proximal to the stenosis at maximal vasodilation. Fractional flow reserve is measured using a coronary pressure sensor guide wire at rest and at maximal hyperemia following the injection of adenosine. A fraction flow reserve of below 0.8 indicates a hemodynamically significant stenosis that would benefit from intervention. Using both pressure and velocity, an index of myocardial resistance can be also calculated. Studies have shown this to be an important predictor of outcomes as well. So here is the results of pressure in the coronary artery distal to the stenosis, green number, and this result was divided by the pressure in the artery proximal to the stenosis, red one, at maximal hyperemia following the injection of adenosine. Fractional flow reserve is less than 0.8. That indicates that revascularization would be beneficial for this patient. Aortic valve disease. Now let's discuss surgical approach in case of aortic valve diseases. Aortic stenosis. Aortic stenosis occurs in about 1/40 of all patients with chronic valvular heart disease. About 80% of adult patients with symptomatic valvular aortic stenosis are male. The valve gradient in the aortic valve area can be estimated by Doppler measurement of the transaortic velocity. Severe aortic stenosis is defined by a valve area less than 1 centimeter square. Aortic valve sclerosis, conversely, is accompanied by a jet velocity of less than 2.5 millimeters per second. Surgical treatment. Operation is indicated in patients with severe aortic stenosis when a valve area is less than 1 centimeter square. Who are symptomatic, those who exhibit left ventricle systolic dysfunction, or those with bicuspid aortic valve disease and an aneurysmal route of ascending aorta. The indications for surgical replacement in the asymptomatic patient have been the subject of intense debate. As surgical outcomes in selected patients have continued to improve, relative indications for which surgery can be considered include an abnormal response to treadmill exercise, rapid progression of aortic stenosis, especially when urgent access to medical care might be compromised, very severe aortic stenosis defined by an aortic valve jet velocity more than 5 millimeters per second, or mean gradient more than 60, and low operative risk, and excessive left ventricle hypertrophy in absence of systemic hypertension. Percutaneous aortic balloon valvuloplasty. This procedure is preferable to operation in many children and young adults with congenital non-calcific aortic stenosis. It is not commonly used as definitive therapy in adults with severe calcific aortic stenosis because of a very high restenosis at rate 80% within 1 year and the risk of procedural complications, but on occasion it has been used successfully as a bridge to operation in patients with severe left ventricle dysfunction and shock who are too ill to tolerate surgery. It is performed routinely as a part of the TIVR procedure, so transcutaneous aortic valve replacement. TIVR for treatment of aortic stenosis has been performed with increasing frequency of prohibitive, high and intermediate surgical risk. Adult patients worldwide using one of two available systems, a balloon expandable valve and a self-expanding valve, both of which incorporate the pericardial prosthesis. TIVR is associated with an early hazard for stroke and a higher incidence of post-procedural paravalvular aortic regurgitation, a risk factor for mortality over the next 2 years. The rate of post-procedural heart block requiring permanent pacemaker is about 10%, is significantly more common after TIVR. This is two options of transcatheter devices. This is balloon expandable, A option, and self-expandable, B option. This is inflated balloon, nose cone, and valve, which must be placed into the aortic valve position. So surgical treatment. In deciding on the advisability and proper timing of surgical treatment, 2 points should be kept in mind. Patients with chronic severe aortic regurgitation usually do not become symptomatic until after the development of myocardial dysfunction. And second, when delayed too long, defined as more than 1 year from onset of symptoms or left ventricular dysfunction, surgical treatment often doesn't restore normal left ventricle size and function. Therefore, in patients with chronic severe aortic regurgitation, careful clinical follow-up and non-invasive testing in echocardiography at 6 to 12 month intervals are necessary if operation is to be undertaken at the optimal time, after the onset of left ventricular dysfunction or prior to the development of severe symptoms. Aortic valve replacement is indicated for the treatment of severe aortic regurgitation in symptomatic patients, irrespective of left ventricle function. In general, the operation should be carried out in asymptomatic patients with severe aortic regurgitation and progressive left ventricle dysfunction, defined by and left ventricle ejection fraction less than 50%, and left ventricle end systolic dimension more than 50 millimeters, or a left ventricle diastolic dimension more than 65 millimeters. This is algorithm of surgical approach in aortic valve disease treatment. So you can see here when aortic valve replacement is indicated, when sometimes we prefer periodic monitoring. Mitral valve disease, mitral stenosis. Rheumatic fever is the leading cause of mitral stenosis. In normal adults, the area of mitral valve orifice is about 4 to 6 centimeters square. In the presence of significant obstruction, it means when the orifice area is reduced to 2 centimeters square. Blood can flow from the left atrium to the left ventricle only if propelled by an abnormally elevated left atrioventricular pressure gradient. the hemodynamic hallmarks of mitral stenosis. When the mitral valve opening is reduced to 1.5 centimeters square, referred to as severe mitral stenosis, and left atrial pressure of 25 millimeters mercury is required to maintain a normal cardiac output. To assess the severity of obstruction hemodynamically, both the transvalvular pressure gradient and the flow rate must be measured. So, mitral valvulotomy. Unless there is a contraindication, mitral valvulotomy is indicated in symptomatic patients with isolated severe mitral stenosis. Those effective orifice is less than 1 centimeter square. Mitral valvulotomy can be carried out either percutaneously or surgically. The short and long-term results of percutaneous valvulotomy in appropriate patients are similar to those of surgical valvulotomy, but with less morbidity and lower periprocedural mortality rate. Mitral valve replacement is necessary in patients with mitral stenosis and significant associated regurgitation. Those in whom the valve has been severely distorted by previous transcatheter or operative manipulation, or those in whom the surgeon doesn't find it possible to improve valve function significantly with valvulotomy. Regurgitation is now routinely performed with preservation of caudal attachments to optimize left ventricle functional recovery. This is approach to rheumatic mitral stenosis treatment when we choose mitral valve surgical treatment or periodic monitoring and conservative treatment. This is Inouye balloon technique for percutaneous mitral balloon valvulotomy. You can see here that after transeptal puncture, the deflated balloon catheter is advanced across the intra-atrial septum, then across the mitral valve and into the left ventricle. The balloon is inflated stepwise within the mitral orifice. That's how does it works. Mitral regurgitation surgical treatment. These risks are significantly lower for primary valve repair than for valve replacement. Repair usually consists of valve reconstruction using a variety of valvuloplasty techniques and insertion of an annuloplasty ring. Repair spares the patient the long-term adverse consequences of valve replacement, including thromboembolic and hemorrhagic complications in the case of mechanical prosthesis and late valve failure necessitating repeat valve replacement in the case of bioprosthesis. Surgery should also be recommended for asymptomatic patients with left ventricle dysfunction characterized by an ejection fraction less than 60% or in left ventricle and systolic dimension more than 40 millimeters. Other indications for early consideration of mitral valve repair in asymptomatic patients include first, recent onset of atrial fibrillation, duration less than 3 months. Second, pulmonary hypertension, defined as a systolic pulmonary artery pressure more than 50 millimeters mercury at rest. And third, a progressive decrease in left ventricle ejection fraction or increase in left ventricle and systolic dimension on serial imaging. And next is transcatheter mitral valve repair and replacement. A transcatheter approach to the treatment of either primary or functional mitral regurgitation may be feasible in selected patients with appropriate anatomy. The proper role of currently available techniques remains under active investigation. One approach involves the deployment of a clip delivered via transeptal puncture that grasps the leading edge of the mitral leaflets in their mid portion. Other approaches include the deployment of a device within a coronary sinus that can be adjusted to the reduced mitral annulus circumference and the effective orifice area of the valve, much like a surgical implanted ring. This is main algorithm of mitral regurgitation surgical treatment. When we choose mitral valve repair with surgery, but sometimes we can mitral valve replacement tactics, where we can choose replacement tactics. Thank you for your attention. I've finished. Goodbye.